Very good afternoon and welcome to this webinar on management of asthma in children. And in particular, we'll be talking about the utility of lung function, allergy testing, and other investigations like assessing inflammation in management of childhood asthma. I am Dr. Ankit Parak and I work as a consultant in pediatric pulmonology, allergy, and sleep medicine at BLK Hospital and Children's Chest Clinic at New Delhi. So we'll talk about that. How do we usually diagnose asthma in children? What are the guidelines regarding the GINA and the IAP guidelines? And we'll also talk about the utility of doing a lung function, including a spirometry, newer modalities like oscillometry, allergy testing, and measuring airflow and measuring airway inflammation. Now, we all know that all pediatricians do manage asthma and we have been doing it for the past many years. And usually it is a clinical diagnosis. Now, what we are trying to look at is that is the clinical judgment enough, or do we need to bring about a change in the way we are managing our asthma children? Or better said, that for a small subset of patients, do you need to investigate them further? What investigation and when? So that is the agenda for this webinar. Now, we all have been realizing that asthma is not one diagnosis, rather it is an umbrella term, or it is more of a syndrome. And it involves a lot of phenotypes. So what is meant by a phenotype is that there are certain set of symptoms and signs which you can identify and you can classify your children into. So phenotype is something which is clinical. And this phenotype can also be associated with something which is known as an endotype. And these endotypes can be recognized by a biological marker. So there's an underlying biological mechanism which tells us that it has an endotype. And there is a phenotype endotype correlation which can be there. And gradually, if you read literature, then a lot of things are actually coming on to the endotypes, especially in children with severe asthma and in a lot of adults. Now, if you look at phenotypes of asthma in children, then there's a lot of data which comes up from the cohort studies which have been done world over. So you have a set of patients who have a viral wheeze and who gradually wanes off, but you also have a set of patients who start wheezing early, but they keep on wheezing. Now, there's also a group of patients who would lose to wheeze around mid-childhood. You have a set of patients who start wheezing in school age groups. You can have a group of patients who actually start wheezing in adulthood. Now, why does that happen? Or are these children different? Are they to be managed differently? So that is what we are trying to look at. And these phenotypes, what we have talked about, as I said, are associated with endotypes. And these endotypes could be allergic or non-allergic. So they can be eosinophilic asthma, which is an allergic eosinophilic asthma. It can be an eosinophilic asthma, which is actually non-allergic eosinophilic asthma. It can be a non-eosinophilic asthma, which can be either a neutrophilic variety or a polygranulocyte, where actually you do not find a lot of cells. Or it can be a mixed granulocyte, so you find eosinophils and neutrophils as well. So these are what are endotypes of asthma. Now, what we have been usually doing is that we have been looking at symptoms. So is this child, coughy? Is this child wheezy? Do we have a pattern for this? We are also looking at exacerbations. So we are looking at how many exacerbations have been there. We have been looking at the severity of exacerbations of this child. And we have been looking at the response to medicine. So we have been looking at whether this child during this episode responds to bronchodilators and responds to steroids as well. And that helps us to understand whether this is a reversible airflow obstruction or not. And that helps us to decide the long-term management and also helps us to look at diagnosis. Now, this is the usual way we have been looking at asthma, right? But there is also a set of things which can be done. Uh, should we look at lung functions? Will it help us to understand things better? Should we look at sensitization or allergen sensitization, which will help us to understand what is actually driving this asthma, if this is actually allergic? And at the end, asthma is an inflammatory disorder. So will assessing lung function help to manage children better? Will it help us to fine tune our management better? Will it help us to decide things better? So we are trying to look at the utility of these investigations over and above our clinical diagnosis. And obviously, when you're looking at all these things, you're obviously looking at clinical markers to look at mimickers of asthma. So the key question is that how does doing a lung function, allergen testing, assessing airflow inflammation add on in the management of asthma in children? So does it help in diagnosis? Does it help in defining asthma control? And does it help us in treatment of these children? So how have been we being diagnosing asthma? We've just talked about it. So what Gina says is that we have to look at the cardinal symptoms, which are wheeze, which are shortness of breath, chest tightness, and cough. And the description can vary. And now, generally, children will have more than one symptom. So it is not just wheeze or just shortness of breath or just cough in the Gardner variety of asthma, but you can have isolated things as well. So usually these symptoms would be variable in time and variable in intensity. So sometimes they are more, sometimes they are less. In some seasons they are more, in some seasons they are less. They can be a diurnal variation, so they're usually worse at night or they're worse when the child awakens in the morning. These symptoms are usually triggered by exercise, laughing, allergen exposure, and cold air. And you can have symptoms which seems to get worsening with viral infections. So this is what has been the symptom set which has been described by GINA or any other world organization, and which includes the IAP guidelines as well. But we have a certain set of symptoms and some guidance for under 5 children as well. Now, if you look at the this side of the slide, then you will find that it says that symptoms are there for less than 10 days with viral infections. There are 2 or 3 episodes a year, and in between episodes, the child is asymptomatic. And it says that few children will have asthma. So this is pertaining to children who are under 5. Now, if you gradually go on to the right side, you will find that in the middle one, the duration of episode actually increases for more than 10 days. The number of episodes increase to more than 3 episodes a year or severe episodes. And even in between episodes, the child seems to be symptomatic with cough, wheeze, or heavy breathing. Now, in these, if the child has this symptomatology, then it says that some will have asthma. And if you go on to the extreme right, what is added on here is allergen sensitization, presence of atopic dermatitis in the child, presence of food allergies, or family history of asthma. So, which means that if there's an underlying uh, allergic background to this child, or this child already has some form of allergy which is already manifested, then the chances of this being asthma are significantly higher. So this is a probability based algorithm which has been given by GINA 2020 for under 5 children. Now again, it is again based on a probability as we are looking at this. Now it also says that we should confirm this by doing a lung function test. It does not specifically mention adults or children, but any child who can perform lung function should be done. And it says that you should document a lung function. So you should document an expiratory airflow limitation. So which means that the FEV1 by FVC ratio has to be low at one point of time, and And in addition to this, the FEV1 has to be low. So that will prove that it is an obstruction. And we also need to prove that this obstruction is actually a reversible airflow obstruction. And the commonest way we do it is by giving a bronchodilator and seeing what has been the improvement with the bronchodilator after 15 to 20 minutes when we repeat the spirometry. So improvement in 12% or a more than 200 ml change from baseline is suggestive of reversibility. Now, if there is no reversibility, then some people will look at an exercise challenge, which means that you ask the child to exercise, and then if the FEV1 falls by more than 10% or 12% in children, then it is considered to be reversible. So this is a challenge test as compared to a bronchodilator reversibility, where you are trying to look at improvement. And some authorities will also look at, especially in adults, at the variability in the peak expiratory flow rates over 2 weeks. Now, we all know this. Now, the question is that why PFTs are not done in children routinely? Well, there are reasons to it, and there are valid reasons to it. Now, when you talk to anyone, right? So a lot of people might think that it does not add on to my clinical diagnosis. If all these things are present in a particular patient and I can manage this patient, then will it actually add on to say that this child has asthma or not? I know this child has asthma, right? And I also do understand that a lot of children may not be able to perform a lung function, and they might come back saying, "Doctor साहब वो ठीक से तो हुआ ही नहीं है." And it's not something good which anyone would like to see, that you have sent a child for an investigation and it has not been done properly. Now, the third thing which anyone would say is that in follow-up, the child looks absolutely well. The child is not having symptoms. This child has done very well on inhaled steroids. So do you think doing a lung function and follow-up will actually help to manage this child? I can follow up this child clinically, and I've been doing that for years. The next two problems are that where should I get a lung function from? And if you say a good quality lung function, then is it actually available to me? And there might be issue of a cost as well. So let's try and answer these questions in context of children with asthma. Now, when we talk about lung functions, then we need to know that there have been a lot of advances in the spirometers and the spirometry softwares. Now, most of them are either ultrasonic or pneumotag based, and a lot of these softwares come up with very good animative programs, computer animation programs, which can actually assist the child in doing a lung function test easily. So you don't need to scream and yell on the child to blow out, blow out, and blow out. Rather, these children would actually enjoy to play these games. These are volume incentives and these are flow incentives which are available. And this has made the life of children and the person who is doing the test, really easy. And definitely the cooperation increases. So that is something which we need to know. And you also need to know that there are ways to improve the quality of spirometry. The technician has to be good. He should be, cooperative with children. He should be able to teach all the parts of how a spirometer, how the maneuver is to be performed. We need to talk to the parents. We need a lot of encouragement to the child, a positive reinforcement, a reward. So we would always tell children that once you do this, you will get a lollipop. You'll get 2 lollipops, and a lot of children are happy when they get one. And sometimes they would refuse to do it. They will not do it. So we still don't get angry with them. We praise them, and we can rebook an appointment and do it at a later date. Now, I'll give you a few examples of how lung function can help us. So this is a 14 years old child who has an exertional breathlessness for the past 2 years. This child is not coughing, not wheezing. There's no seasonal variation. There's no family history of asthma. So these are doctor parents, and they have seen multiple pediatricians, and all investigations have been normal. Now, no one knows what's going on. This child has not been an asthma in the past. So once we saw this child, the chest was clear, and we weren't clear what's happening. So because the breathlessness was mainly exertional, I thought that let's do a treadmill exercise challenge spirometry to see whether this child actually has an exertional or an exercise-induced asthma. So this child came with his jogging shoes and everyone was ready for doing a treadmill exercise challenge. So before doing a treadmill challenge, we would always do a baseline spirometry. And this is what happened. So if you look at the baseline spirometry clearly shows an obstructive curve. So the blue curve is the obstructive curve. It clearly shows obstruction. The red curve is the post bronchodilator curve, which clearly shows an improvement. And if you look at the values, then there's a significant improvement in the FEV1s post bronchodilators of 26%. So this child actually has an asthma, which we could not otherwise would have diagnosed if there was no lung function which was available. So again, it is a partial manifestation where you do not find a garden variety where you find everything fitting into a clinical picture. Now let's look at one more child. So this child is 7 years old, has recurrent episodes of cough for the past 2 years. The cough is mostly dry in the morning, especially when the child is sleepy, and it is there with exertion, laughing, crying. Now, 2 to 3 weeks the episode would last. The child remains well for a month or two, and again as a recurrence. Now, this child responds to oral salbutamol, has never been nebulized. So sometimes we get patients who are coming from the rural background, and it becomes difficult because the documentation is not as good, and sometimes they're not getting nebulized or inhaled drugs. There is some seasonal variation. There are no other cuff pointers. No wheeze has been documented. And when you examine this child, again, the chest is clear. So it looks like this child is possibly having an asthma like issue. Are you sure about it? How will you convince parents? Are you convinced? Would you put them on inhaled therapy for how long? You have not been able to document a wheeze and you do not have a very clear presentation. So wheezing wasn't documented. Can this still be asthma? Well, most likely it is an asthma. That is what we are looking at. Again, a lung function shows obstruction and reversibility and things clear out. So you're done with a basic simple spirometry. And again, you have corroborative values showing obstruction and showing reversibility. So FEV1s were 49%, and in the second, they came out to be 68%. So showing obstruction and reversibility clearly. So the first thing which I want to tell you here is that you can have presentations of asthma which are the form first representations, clinically ambiguous things. So the child presenting only with a cough variant asthma, only with exercise induced symptoms, only with nocturnal cough. So these children are not rare, and no one exactly is sure that this is an asthma or something else you are dealing with, because you definitely have more differential diagnosis which you are thinking about in such situations. And in these partial manifestations, it is extremely important to get a lung function to clinch the diagnosis. Now, let's look at a follow-up thing. So this 12 years old boy is a known case of asthma, is on budesonide formoterol 100 micrograms. Now, this child comes from somewhere from Assam, and so we saw this child somewhere in June. So 3 episodes of wheezing, they said, from October to February. But after that, the child has been well. So there's no cough, there's no exercise-induced symptoms, no SABA use. Now, what would you do? Is it a well-controlled asthma? Would you taper drugs or stop drugs? So we thought we'll possibly taper drugs and plan out to stop the drugs if the child actually remains same. But what wasn't very convincing was 3 episodes in winter, although this child was well for the past few months. So we thought, let's do a lung function. Now, when you do a lung function, this is what you find. A lung function showing significant obstruction, no reversibility at that time, FEV1 values of 66%, less than 2 standard deviations. So this child actually, you see this child clinically, this child is absolutely well. This child is not wheezy. This child is not coughing. This child does not have any other symptoms. But this child definitely had got a significant obstruction, which would be missed if lung function is not done. And similarly, this 8 years old girl who is a known asthma was on ICS prophylaxis. It was tapered and stopped, and the child remained well. So now this child comes in follow up after 3 months. This child is clinically well, and the parents ask me, "Doctor, do you think everything is going on well? Do you think the disease is not coming back? Do you think any other thing needs to be done?" I said, yes, a lung function needs to be done, because this child has been a persistent asthma for years. And once we have stopped inhaled corticosteroids, the things might come back. So let's do a lung function and see what's going on. And again, what you see is and a spirometry which shows obstruction, and a spirometry again which shows reversibility in lung functions. So again, if you look at follow-up, and there's a lot of data which comes up from publications, and these publications are a bit old because I think in the Western world, in most clinics, especially in pediatric respiratory clinics, they would be doing spirometries. So this issue actually has not been something recent but old. Now, if you look at this data, so this talks about of two cohorts of children. So what they were looking at is that if you look at only symptoms versus symptoms and lung function, then what would happen to classification of asthma? So if you look at this part of the graph, so if you look at the upper part of the graph, if you look at this part of the graph, then it shows intermittent asthma, this many, mild persistent this many, and severe moderate to severe this many. But if you look at addition of lung function, then it leads to a classification change in a lot of patients. And if you read this article, then they say that approximately 25 to 30% of patients actually were reclassified once their lung function was done. So what we are doing clinically during follow-up, especially for moderate to severe patient, is that we are underestimating the degree of obstruction clinically. So that is what this data shows, and there are lots of paper available, but as I said, old papers because the issue is actually a bit old. Now, we have talked about the conventional problems which we would get, partial manifestations and follow-up and how to use a lung function. But there are other problems as well, which we haven't talked about. So for example, I get a lot of children under 5 who have had chronic cough. And when I examine these children, this child is not wheezy. Now, what am I dealing with? Am I dealing with a sinusitis? It is a bacterial bronchitis. Is it actually an asthma? Uh, 2, 3 people already have seen this child. This child is not wheezy. And parents would ask me, Doctor, is there any way to confirm it? A 5 years old child has got asthma or a suspected asthma, but has failed to do a spirometry. What should I do? Either I manage it clinically and convince parents, do I have another test where I can do and look at things? And there's another circumstance which now gradually creeps up. A 6 years old suspected asthma but has a normal spirometry. Is it not asthma? Am I dealing with something else? So we have a newer investigation, and I would say just newer, not very new, because it has been available even in the Indian setup for the past 7, 8 years, but not as much. So this is something known as an impulse oscillometry. And so what this does is that it produces sound waves. So this is a sound box which is there. So these sound waves are produced, and once these sound waves are produced, it goes across this resistor and reaches to the pneumotach. And the child is actually holding on to the pneumotach and breathing. Now, and when the child breathes, the tidal breathing of the child, so remember, this is a tidal breathing maneuver. The child does not need to forcefully expire like a spirometry is done. So it is a tidal breathing maneuver. It can be done in any child beyond 3 years of age. The textbook will say 2 years of age, but our experience between 2 and 3 years has not been very good, because most of them become very apprehensive and they start crying and yelling. So we try and offer them after they are 3. So once the child is breathing, the tidal breathing of the child gets superimposed on the sound waves which are coming from the loudspeaker, and this is what is recorded by the pneumotach. So this is a loudspeaker, and through this the sound waves would go, and the mouthpiece is there where the child is breathing. So what happens is that these sound waves actually goes in the airways, and what we understand is that the sound waves of lower frequency can travel farther. On the other hand, sound waves of higher frequency are limited to the smaller airways. And that helps us to know whether it is a peripheral airflow obstruction or it is a central obstruction. And now what you get is a different set of values. What we have been looking at for spirometries is FEV1s and FVCs. But what you look at in this investigation is you get resistance and you get something known as reactance. And the resistance you get resistance at 5 hertz to 40 hertz, and again you get reactance from 5 hertz to 40 hertz. And if the resistance is actually higher at lower frequencies like 5 hertz, but not at 20 hertz, it actually tells us that it's a distal airflow obstruction. Now, we have been doing this investigation for the past 7-8 years at least, and we did a thesis on 100 patients. So this was a part of a DNB thesis program which we were doing. So for the first time, we actually took 100 patients, and what we said was that we will do spirometries and we will do oscillometries both in all patients and look at what is the difference. So we had a set of 100 patients, 61 had suspected and 39 were known asthma, and they were controlled, partially controlled or uncontrolled. So what we found was that a lot of patients had a positive results on a impulse oscillometry, but a lot of them on a spirometry did not show a significant obstruction. So although we know that the classical investigation or the best investigation which has been recommended is spirometries, but there is a group of patients which actually have a small airflow, small airway dysfunction. That is what it is now defined as, where they will have obstruction on oscillometry but may not have on spirometry. But there's a group of patients where the spirometries are abnormal and the oscillometry appears to be normal. So what we have been doing now for the past 2 to 3 years is that because we have the equipment both at the clinic and the hospital, we do an oscillometry and a spirometry both, because the equipment is the same. It hardly takes 2 minutes extra, and it definitely gives us much better results as compared to doing just one investigation. Now, to come back to the cases which I had shown you. So this is a 3-year-old boy who presents to us with chronic cough and no wheeze. And once we do an oscillometry, the R5 values are significantly increased. So something like 100 is normal. These values are significantly increased to 138. And once you do a bronchodilator reversibility, then it reduces by 35%. So actually the resistance values actually reduce once you give bronchodilators, and it definitely helps us in management, showing that there's obstruction, there's reversibility, and we need to follow up this child on inhaled corticosteroids. Again, 5-year-old child could not perform a spirometry, performed an iOS easily, and again the R5 values shows significant obstruction, 162%, and so significantly raised R5 values. This time we could not document a reversibility, but once you put them on inhaled corticosteroids, you can follow up these children and you can repeat it and see whether after giving inhaled corticosteroids they are reversible or not. And the third child, so 6-year-old child, looks like an asthma. The spirometry is absolutely normal, no obstruction, no reversibility. And once again you do a oscillometry, you find the R5 values are raised and it shows significant reversibility as well. So there's a definite role of doing oscillometries in our children who present with asthma. I'm not saying in all patients, it's a group of patients which would benefit. There's a well-known fact that they have small airflow or small airway dysfunction, which may not be picked up with a spirometry, which actually is looking at larger airways as compared to smaller airways, which oscillometry can look at. And there's data which says that even if you want to look at the control, then the follow-up with oscillometries can be quite helpful, because we do understand spirometry sometimes are normal during follow-up, but iOS shows obstruction. And in those patients, we would actually wait and not reduce medicines, follow them up, and once their oscillometry turns back to normal, we would actually go on and reduce their medicines. And a lot of things which have been described regarding oscillometries. I'll not go into a lot of details because we don't have time for that. So to summarize about lung functions, that it is really useful if you're looking at clinically ambiguous situations, if you're looking at partial manifestations like cough variant asthmas, exercise-induced bronchoconstriction. You're looking at poorly controlled patients on therapy. And it obviously is a hallmark for diagnosis. It gives certainty and it gives confidence to parents. We're not trying to say that you cannot manage an asthma without doing a lung function. No, that is not the message which should go across. The message is that in a group of patients, it is going to be really helpful and you cannot do without that. It requires good coaching and animations, and with the availability of impulse oscillometry, we cannot say that children cannot perform spirometries. I do understand that we have less pediatric PFT labs, but gradually they are coming up. There are more pulmonologists which are available, but it should be done from a good quality lab, especially who are doing pediatric spirometries, because if anyone does it and the quality is bad, then you're going to lose faith in the investigation, and that's not good. So it should be done from a good place, that is for sure. And during follow-up, it is good for assessing the degree of obstruction and in defining control. So it should be done before the start of treatment, but if the child presents to you with an acute flare, then obviously you're going to treat this child and not do it at that time. You can do it in the interval, but sometimes it can be normal during the interval because the child is already treated. And if you have a diagnostic dilemma, then you can repeat it once the child becomes symptomatic again. And during follow-up, it can help you in looking at control. Oscillometries, it does not mean that if we have it, then all children should get it. Uh, if you have a young child where you suspect asthma, yes. If you have an older child where you suspect asthma and the spirometries are either normal or the child is not able to do a spirometry, then the answer is yes. Now let's go on to the second topic, which is allergen sensitization and allergy testing in children. So what has been understood world over at most centers practicing allergy and pulmonology is that there are reasons to identify the allergen to which a patient is sensitized beyond the need to establish an accurate diagnosis. So we know it is an asthma. The question is that how does an allergy testing add on? How does it help me in managing patients? Uh, I know this is an asthma. I know this. I have to use inhaled corticosteroids, and my child is well. So, what is the need? What is the need to get this new investigation done? So, well, the reasons are that a targeted avoidance of relevant exposure improves outcome, and it is more effective than untargeted avoidance. If you know to what the patient is sensitized, then, and especially with the seasonal thing, then you can help them initiate uh, prophylactic treatment and avoidance in a timely manner, and you will have a small subset of patients who would warrant immunotherapy. And unless until we know the allergen sensitization, how can we offer them immunotherapy? Now, this is the IACI guidelines, and it's a very beautiful paper which has been written on testing allergies in children, when, how, who, and when. And if we look at the respiratory allergies, allergic rhinoconjunctivitis or sinusitis in addition, so seasonal, if it is resistant to treatment, not all, obviously. A perennial rhinoconjunctivitis, when you do not know the allergen, because these are the group of patients who have bad quality of life. Now, all children with persistent asthma, so if they have symptoms throughout the year and they are on inhaled or something throughout the year, then yes, in this group of patients we need. Or if the children are having more than 3 episodes of wheezing which are not related to viral infections, then we need to identify the allergens. Acute urticaria, usually no, unless until you think that this is an IgE mediated reaction, not indicated for chronic urticaria. It should be done for patients with anaphylaxis, especially if you're not very clear about the trigger. Now, what tests do we have? You have a skin prick test or skin allergy test, that is the gold standard. And we have the serum specific IgEs which are available, which are backup diagnostic test. Now, the difference is that the skin prick test picks up the IgE which is bound to mast cells and which is the predominant thing. On the other hand, the serum specific IgE will actually identify only the circulating IgEs. So that is the major difference which is there for skin test versus the blood test. And the sensitivity of skin test has been definitely higher as compared to blood test. So what is basically done is, on the skin, we apply a drop of the allergen. So this is a dust mite allergen which we have applied. And with a skin prick lancet, which is 1 mm, not the blood lancet, which is 3 mm, you're going to gently lift the skin or scratch the skin so that this allergen actually seeps down into the epidermis. Now, once that happens, the mast cells which are already sensitized to the dust mite allergen would reach up here, catch up this allergen, they would degranulate, release histamine, and it leads to a wheal and flare reaction. And this happens in 15 minutes. And you can test multiple allergens. So you can test indoor aeroallergens like dust mites, animal dander, cockroach, and molds. You can test outdoor aeroallergens. They're variable throughout the country and throughout the world. Then food allergens, if there are actually any, you can test insects and venoms if you actually need to. We're not saying that they should be tested in patients with asthma, but it's just to complete the SPT part. So this is what we use. Different people use different panels for their patients. So the indoor allergens remain actually throughout similar across the world. So usually dust mites, some people might test a few mites more. So usually dermatophagoids, Farinae and Pteronoeus is the usual thing which is done. Then dog, cat, cockroach, because that is something important in Indian setup, and usually a few fungus, the most important being Alternaria alternata and Aspergillus fumigatus. And then, as I said, the pollens might be different. So if you're looking at European centers, they would be doing mainly birch. They might be doing alder and oak and things like that. And they would be doing temperate grasses. On the other hand, people in India would be testing more of amaranthus and cynodon, mugwort, and they would be testing more of tropical grasses as compared. So we're not going to real details of that. You can test a lot of foods, but as something which should be clear, food allergens are really not implicated in children with asthma unless until you find a very clear history which tells you that there's an immediate reaction to food. Otherwise, they should not be tested. Most parents will say that my child is allergic to this or this or this, but unless until you have a conclusive history, you should not test them, because it will lead to a very high false positivity rate, which is something which is not uh, good. And we have seen a lot of patients who undergo an avoidance to all these things and nothing happens. So how we do it, we would mark the allergens starting with a negative control, these allergens like in this order, and you have a positive control, which is a histamine. Then you put drops of these allergens, then you scratch them. Usually saline first, you go across, and at the end you would do histamine because histamine reacts fast. And you wait for 10 to 15 minutes and then you read the results. And this is just an example. So this child is highly sensitized to dust mites. So DF is dermatophagoids, Farinae and Pteronoeus. And this child is actually not sensitized to anything else. It shows a positive and negative control. So this child is sensitized to Aspergillus, to Alternaria alternata. This child is sensitized to multiple things. So this is a polysensitized child, to dust mites, to cockroach antigen, and to amaranthus. So if you're looking at allergy testing, then it helps in allergen avoidance, and occasional patients will need immunotherapy. So allergy testing is not equivalent to an immunotherapy. That is something which we all need to remember. There would be a few patients who would need immunotherapy. So we do understand that it is an upcoming modality for treatment of children with rhinitis and asthma. So if I talk about just asthma, what we understand is, if you have a child who has a persistent asthma, who cannot, go off inhalers, you've seen that for a year, 2 years, and this child is sensitized to a few allergens, most importantly being dust mites, then it is something which can be tried. Especially, we have good data in children more than 12 years of age. You have emerging data in children who are between 6 and 12, but the trial is still on. For the rest of the allergens, we do not have as strong data for allergen immunotherapy for asthma. For rhinitis, it is a different issue. Now, let's go on to the last part, which is assessing airflow or airway inflammation. So Why do we need a new test? Because it tests the airway inflammation, and it adds on a new dimension to the traditional clinical tools of history, examination, and doing a lung function. Well, there are lots of things in literature which can test an inflammation in the airway, from bowel and biopsies to volatile organic compounds. But what has been used most frequently in clinical practice, because being non-invasive, is a pheno, or the exhaled nitric oxides. So what happens is that usually the amount of NO which is produced uh, from the cells is low, but once asthma is there, then the activated cells produces a lot of exhaled nitric oxide. So that is the basic thing, and it has been a surrogate marker for eosinophilic airway inflammation. So that is the basic background doing a pheno. So it is a non-invasive test. You can repeat it. It can be performed in children as young as 4 years of age. It is relatively easy to use even in patients with severe airflow obstruction. Now, if you look at data, how pheno would help. So if you look at diagnosis, then the range has been quite wide. Something, as you can see from the slide, somewhere from 43 to 88% for the sensitivity, and 60 to 90% for specificity. And what they have calculated is that approximately 1 in 5 children with positive pheno will not have asthma. And conversely, 1 in 5 with a negative pheno will have asthma. So the false negatives and false positives are significantly high. So in most part of the world, people don't really prefer it for a diagnosis. There's also a meta-analysis which talks about that if you fine tune your medicines as taking into account pheno, then what happens? So what has been seen across is that the exacerbations reduce, but the amount of inhaled corticosteroids also go on increasing in this group of patients. But uh, you cannot reduce the corticosteroid use. You cannot reduce the secondary outcomes like lung functions or the daily symptoms. So that don't actually decrease even if you take into account the pheno, and the inhaled corticosteroid doses definitely go up. So most guidelines have said that it should not be used for all patients, uh, but it should be used for some patients who are there and who have a severe asthma with at specialized centers. So it is a marker for eosinophilic airflow or airway inflammation, but the utility is limited. We need more clear protocols. The evidence that it helps to decide or guide steroids is mixed. It can be used for difficult to treat asthma and ciliary dyskinesia patients where you use nasal nitric oxide. So just at the end, we need to know that, and what we understand from all this is that if you have a patient where the diagnosis is plus minus or ambiguous, yes, you need a lung function. You need to do lung function or two in follow up to understand that they're doing well. Now, but you will have a group of patients, and we have that group more because all of my patients would be referred from you all, and they're more moderate to severe patients. And in these group of patients, definitely these investigations would really help. So if you have a difficult to treat asthma, you confirm diagnosis, consider a differential diagnosis, look at factors which are contributing to symptoms, exacerbations, and a poor quality of life. And you optimize the asthma education, the technique, adherence, comorbids, and then you decide a step up. Now, once you're coming at step 4, and this I have taken from the booklet which comes from Gina, and it is available on the net regarding severe asthma management in adolescents and adults, and there are few steps which are common for children. So you follow up these children for 3 to 6 months, and if they're still poorly controlled, then you will call them as a severe asthma. And at this point of time, you actually need to phenotype these patients before going ahead. So step 5 is assessing asthma phenotype. So you have to get a pheno done, FENO. You have to look at blood or sputum eosinophils. You have to get a skin allergy testing or an immunocap, which is your serum specific IgE done. You actually cannot go forwards without these investigations and obviously lung functions. Now, if you have a child who is eosinophilic phenotype, then you have options like smart inhalers, high dose inhaled corticosteroids, tiotropiums, and alternate diagnosis. And you have some options for non-eosinophilic phenotypes, but you also have biologicals which can be used for your eosinophilic phenotype. So you have malizumab, and now you have a new entrant in the pediatric asthma field, which is your mepolizumab, which is now approved by the European agencies for 6 years and beyond. So the final conclusion is that most patients will be able to manage clinically. Lung functions are useful in confirming the diagnosis and assessing control. Uh, there's a huge group of patients which will not agree that their child has asthma, and I feel that if anyone is not convinced that a child has asthma, doing a non-invasive investigation is sometimes it's worth it to show that there's obstruction, there's reversibility, and then they become much more adherent to your treatment, and they become confident that yes, what you're doing is right. Uh, Impulse oscillometry is definitely a very useful modality in the specific situations which we have talked about. Allergy testing is useful for assessing sensitization, and it is not synonymous with immunotherapy. But yes, there will be a group of patients who would definitely benefit from immunotherapy. And FeNO has a limited role in the management of asthma in children. So, and these are in brief the services which we perform at our hospital and clinic, which includes bronchoscopy for all ages, including newborns. We extract foreign bodies with flexible scope, all lung function modalities, sweat chloride, allergy testing, and sleep studies. So I would end here, and if there are any questions, then I'll be happy to take them. Do we have any questions?
Yes, sir. There is one question. I have put it in chat box.
Yeah. So how much it costs having an oscillometry done in numbers? How frequently you do it in BLK to spirometry is number wise. So the cost of spirometries can be variable according to the center. So we charge around 1,500 at the clinic versus around 2,200 at the hospital. In numbers, how frequently I do it? So as I said that previously what we used to do was that if a child is not able to perform a spirometry, we used to do an oscillometry, or if a young child, we would used to do an oscillometry, so between 3 and 6 years of age. But now what we find is that doing an oscillometry in all patients and doing spirometry in any patient who is able to perform a spirometry. So any child 4 years or beyond will do a spirometry as well, because as I said, that is the way we do it. I'm not saying it should be do it in the same way. Why we do it is because we find in one sitting you get both the investigation. Sometimes you get positive in either. It helps me in management, and it hardly takes 2 minutes, and I use the same equipment. So it does not matter. We do it for all patients. Uh, Few situations of non-eosinophilic asthma. So if you read up data, then there is a definite group of severe asthma who are not eosinophilic. They are postgranulocytic or neutrophilic. Now the problem is that because no one exactly has a large number of patients with severe asthma, and we do not have a registry as of now in India, and we have not been doing a good phenotyping for these patients. We do not have a database coming up from India. But if you want to read, then there are two large cohorts which have been published. So one is known as a U-Biopred cohort, which comes up from the European Respiratory Society, and the lead is Dr. Bush, who leads from the Royal Brompton Hospital in London. And there's a good data which comes up from the SARC cohorts, or that is the American data. And they have published a lot on severe asthma in children. But a lot of work needs to be done in severe asthma in pediatric age group, especially in Indian setups. And I think our numbers are not less than the numbers what they see in the West. Our numbers might be more. Why we don't see a lot of severe asthma is because a lot of patients are actually not started on inhaled corticosteroids early. The problem is that how do you define a severe asthma? So severe asthma is an asthma who is poorly controlled on 800 micrograms of inhaled corticosteroids with LABA and one more controller, so which is your Montelukast, and now you have tiotropium as well in the armamentarium. So if a child is actually not put on these controllers, then how do you know this child actually has severe asthma? So that is the basic problem. But we need more data from Indian setup. We need to phenotype our patients better to understand what's going on.